All right, now let's talk about other types of IV lines that you may see out there. You may be the person who is taking care of a patient with a central line. Now, a central line is just that. It's IV therapy or an IV catheter that is placed directly into the central circulation. Okay. And central lines always require X-ray confirmation that they're in the right place. These are not something that you're putting in. These are physician lines. Okay. Your patient may they like to use a subclavian, which is this one right here. The entrance site is here, and it's threaded down in toward the right atrium. Or your patient may have a jugular line in. It's in a jugular vein. It's threaded down into the subclavian. Okay. Central lines are used for any time that you're going to need long-term IV therapy. They may be used if you have a trauma or in an emergency situation. Critical care or surgery. Now, while the physician is the one that's putting these in, you may be assisting with that. These can be put in at the bedside. There's usually a central line tray that has all the supplies that are needed. This is invasive, so we get a consent. And then we prep our patient. The patient is usually put in Trendelenburg position. And they usually have like a roll. We have rolled up pillows that we tape to make a really thick roll that we put between their shoulder blades, and it runs down their spine. And what that does is when the patient lays on it, it pulls them back like this. Okay, and then you turn their head to the side so that the doctor can get into this area here. This is an aseptic procedure. Your patient is draped. In your kit, in your tray, there are drapes where the physician will drape the face and around over the chest so that he has a window or she has a window to work in. It is scrubbed. You may be the person scrubbing. But you have to prepare the site, and you may be the one, you're monitoring the patient while the physician is doing this. Remember, we're threading a line down toward the heart, so what do you think you can have some issues with? Cardiac dysrhythmias. So everybody's watching the screen while you're watching the monitor while this is going on. Okay. But we have to, you're monitoring your patient, you're checking on your patient, you may be looking up under the drape to make sure they're okay, talking to them, that kind of thing. But strict asepsis for this. Like I said, infection is not our friend in this situation. Okay. You may also have central lines that are tunneled, like people who are needing long-term chemotherapy. That means that they're tunneled here and threaded up under the skin into the subclavian. All right. Again, you're not doing that, but it is a central line, but it's not up here. Your entrance site is down in the chest usually. Your Hickman cast Boviac cast, those kind of things, those are surgically put in. And we're really using those when your patient is going to have long-term IV therapy. Okay? We're not sending a patient to surgery to have a central line put in an emergency situation. They're doing it at the bedside that way. We're not worried about tunneling and all that business then. Okay, so you may see different types of lines, but again, they're all aseptic. Okay, the physician puts them in. Okay. Now, when we're looking at central lines, they have 2 or 3 lumens usually. Now, this is a triple lumen catheter. And usually what you have is you'll have one 16-gauge lumen and 2 18-gauge lumens. And you can use those for whatever you want to use them for. Right. 2 18s. They come out at different areas in the catheter. And on the tube here, it will say distal or proximal or medial. And that tells you where they're going to come out. The distal one comes out right down here. Medial somewhere up in here, and then proximal is up in here somewhere. Usually your distal one is what we use for blood drawing. It's usually brown. The cap is usually brown. And the distal one is usually the bigger of them. It's usually the 16 gauge. The other ones we may use for TPN or IV or blood. Like I said, whatever makes you happy. Okay? We may not use all 3 of those. And if you have one that is not in use, it should be clamped. This is a slide clamp. Okay, and that's open. You push it over and it kinks it off. Okay, so they should be clamped off, and they should always be capped off. Remember the blue clave end that I showed you on the other picture? You can screw those onto the end of these as well. Okay, these can leak, and if they do, they must be replaced. They don't leak quite as much anymore since we quit stabbing needles into them. Yes, ma'am. Correct. It's in the venous system, so we're not using that for arterial blood gases. You can draw blood out of this, like I said, and when you get to 201, they're going to show you that procedure. You'll have to do that because lab doesn't draw blood from these. You do. Okay, you do. PNs don't mess with these. You do. Any lumen that is not being used has to be flushed routinely. And you will have a protocol in your organizations, but central lines we usually flush with a heparinized solution. We don't use just saline on these because the lumens are so big. And they're longer. Okay. We want to make sure that these people do not get air embolism. Remember, right in the central circulation. That's why we keep them clamped off. If I'm going to change one of those caps, I've got to clamp it. I've got to have my patient turn their head, and I've got to have my patient bear down like a Valsalva maneuver, like they're having a BM, so they don't suck air in. Important. imported. As long as you have fluid in there, they're being flushed. You flush those with a heparinized solution. And heparin it's usually 100 units per milliliter. And it comes that way. You just pull up 3 to 5 cc's and flush it. Okay. You always want to make sure when you take, and if you are taking a central line out, you always want to look at the end of the catheter, just like you do your IV catheters, okay, and make sure that the end is intact. It should be intact. They told you that when they taught you about taking IVs out. Look at it. If it's an IV catheter and all that comes out is that, where's the rest of it? Yeah. Okay. But central lines, you really want to make sure that as well. Okay. Another type of central line is a peripherally inserted central catheter or PICC line. These are usually inserted, again, it's got to be confirmed by x-ray that they're in the right place. So these may be put in x-ray, or they can be put in at the bedside. Nurses with special training are allowed to put these in some places. Okay. But again, your PICC lines, they're peripherally inserted, so it's usually around the antecubital space is where we put those in. These are fantastic for these people who just have no veins. Some people just get a PICC line because you can't get an IV any other way. Yes, ma'am. Yes, if you do it at bedside, they have to go to x-ray to make sure that they're where they're supposed to be. Because see, these are long. These are long, so they're put in and they're threaded up through into the superior vena cava, okay, or maybe into the clavian. I'm sorry, that wasn't coming to me. They may have 1, 2, or 3 lumens. Most of what I've seen have been 2 lumens. So we can use those for blood drawing, for infusion of various, medications. But again, complications are phlebitis, you can get an infection, a bloodstream infection, but it's a little less in PICC lines than you see in the other central lines. And you can accidentally puncture an artery. So there will be a notation by the person who put in the PICC line on how long the catheter is that was inserted, okay, because these are long. These are, 10 inches. The first time I took one out, I didn't realize they were that long. And they're sutured as well. You pull it out, you hold pressure, you look at the end of it, you make sure it's intact. But the first one I took out looked like this. Not like that I was expecting. And so my first thought was, oh my Lord, where's the rest of it? It was still long, it was still that long, but it looked like that. So I immediately called down to the nurse and the x-ray department that put this in and said, hey, Tell me about this PICC line. What was the length of it? Because I was at the bedside at that point. I didn't have time to go and look at the chart and all that business. So she said, we cut it. It was too long for the patient. So before you freak out, they may cut it. They snip the end of it off. I needed cardiac drugs, but the patient was fine. Okay. So just as an FYI, you may see that. It don't necessarily mean that it's been broken off. Yes, ma'am. Mm-hmm. They did the stat lock. Sometimes they do. But you've got to have some type of mechanism to hold those in place. Right. Okay. Yeah, you're right. They're not always sutured in, but they are stabilized. PICC lines are great. And again, if you're not using both lumens, you are flushing. You're flushing. Sometimes you'll have one that won't work and the other lumen will. These are some pictures of them. 2 lumens, and notice they've got clamps on them. This one, they've got clave ends on them. Okay, that you can, this one right here, this one is not being used. This one has got IV fluids going into it. That's what they look like. All right. You may have a patient with an implanted port. These are ports that are surgically placed and tunneled up into the central circulation. They're usually on the chest, the upper chest, or the upper arm. These are for your folks who need long-term IV therapy, usually chemo or antibiotic. But they don't have anything hanging out. It's all up under the skin. So you have to access it. This one is a portacath, or they're calling it a power port. But here's the port here, and then the catheter is a long tube. They thread it up through, and then they put it in the blood vessel. Okay. So you have to access it. Your patient will have a bump on their chest. You can feel them. Okay, and by palpation, you find where that is, and then you access. Right in the middle of it will be a rubber access part. That's where you're sticking your needle. Okay, and this is a needle that is it's short. The needle may be bent at a 90-degree angle, but for these, you clean the site. Aseptic technique. You clean the site. You've got sterile gloves on, the whole 9 yards, okay? And then you are finding your port, stabilizing your port, and then you stick your needle straight down in the middle of it. And then once you do that, you take this down, and it has a tube, and it connects to your IV fluids or whatever it is. If you need to draw blood, you can draw blood. Okay. But if you can keep the needle in while you're doing your IV therapy. You just tape it down and secure it. It's pretty neat. These have to be flushed too. So not only do you have the tubing to flush, but you've got a pretty good sized port here that has a reservoir in it that you've got to make sure you flush that. So we flush these with a good 20 cc's of saline to get the blood and stuff out of there, and then we flush with heparin. If the patient has it long term, the only time we flush those is when we access them. And then we flush them really well when we're done, before we take the IV out, the needle out. Okay. And that, again, depends on your protocol. It depends on your protocol. But we don't access these every 8 hours to flush them. Okay. You can access it, leave it accessed, and then flush it that way. But once you access it, you leave it accessed until you're finished. Okay. Now, if your patient is home, the nurse will come in, access it, do the procedure, whatever they're doing, give the medications, whatever, and then once she leaves, she'll take the needle out, flush it, and then take the needle out. Yes, you flush. Any tube like that, you flush before to make sure it's patent, and then you flush after. Yes. And then heparin. You leave heparin in it. Yep. Okay. There are different kinds of those implanted ports. Some of them are square, some of them are rectangle, triangular, round. You just have to palpate to see what you got there. Okay. And these are, I actually have given the thrombolytics to declot a port like this. Worked well too. Right. Your central line dressings are usually changed every other day. They must be covered by a tegaderm or opsite. And it is a sterile procedure when you do dressing changes on a central line. You guys will do this in 201. A tegaderm or opsite. So central lines, big infection risk. We've got to be aseptic. We're changing our tubing. We're changing our sites. Here they've got the tails, the pigtails kind of taped down. All right, I think we've got one other one. This is an intraosseous line. This is a line that is in the bone marrow. Okay. This one is in the proximal tibial area. You can use these on children. You've got to avoid the growth plate, though, in their bones. But you have a driver, which is a handle that you're holding, that you actually core into the bone. Okay, it leaves the needle, and then you just hook your line up to the needle. You're not doing this. The physician is doing this, or people that are Powell certified, if their hospital allows them to do that, can do this. Okay. This is really not something you're putting in for any long term. This is used more for the resuscitation. Because just think of the consequences if you get these infected. And they've got a new one now that I saw in the spring. That's one, and I can't remember what the name of it is, but they're putting it up into the humerus bone up here, and it's like it just, it's in, you connect it up, and they use those during resuscitations as well because it takes no time for it to go from here to the heart. Pretty neat. It's not this, kind of thing. But I cannot think what you call the thing. Anyway. So you're probably going to see that. EMS is already using it. So you're going to start seeing it, I'm sure, in your ERs and all pretty soon, if not already. Okay. Now, when we're talking about IV medications, and we touched a little bit on IV medications last week, you may be giving IV meds continuously or intermittently. You've got to make sure, though, that it's the correct dilution for what you're giving. Your fluid may be, your medicine may be added to your primary fluid. Things like KCl. You may have a bag that's 1,000 cc's of normal saline with 20 of KCl. Now, the great thing about that is we now have those bags coming to us that are already mixed. You can buy them that way. We used to have to add it every time. Okay? But when it starts coming to us from the manufacturer like that, it cuts out that potential error by somebody having to add the fluid. So it may, but you may be the one having to add it. You may be having to add an extra 20 or, never say that you'll never have to add. Okay, it may come to you in piggybacks. You may have a continuous heparin infusion or a continuous mag solution, mag sulfate. Y'all are learning about mag sulfate, right? Okay. Uh-huh. Yeah, yeah. So those are just intermittent, though. When you're giving like one dose, those are like the intermittent piggybacks. If you have heparin infusing or mag infusing, those are continuous. We don't just stop heparin or just stop mag. Okay? A continuous is also your TPN. Okay? So when we're talking about these kind of continuous things like this, we can piggyback them into your primary, but they're going by a separate pump. Remember, heparin has to go in at a certain rate. You may be titrating it based on the patient's lab values, but it has to be controlled by a pump. The same thing with your mag. Your IV medications that are intermittent, these are your piggybacks. Usually the things that you can use a secondary tubing for. Okay? A fluid bolus, piggybacks, IV push, those are intermittent. And again, you got to make sure you've got the correct dilution here. All of your med rooms will have drug guides. You've got the pharmacy there so that you can, ask those questions and look up those meds. Y'all just thought y'all was going to put the drug guide down when you got out of school, didn't you? It's not going to happen. Sorry. Okay. And again, you have to look at the med, and is it something I can piggyback in with my solution that I've got going? If not, you may need to have another IV access. Okay. You may have to stick your patient again. And that's not a doctor's order. That's you knowing that you've got to have another IV site. Okay. Got to monitor the patient's response. Y'all know that. Saline lock medications. Along the same lines of when we flushed it. Okay, we go in there, we flush it, make sure it's patent, hook up our medicine, either infuse it at the correct rate or push it at the correct rate. Then you flush it again, and you want to flush at the end at the same rate that you pushed your medicine in. I'll say that again. When you're flushing after a medication, you flush at the same rate you gave your medication. Because if you flushed it over a minute, you still got drug in the catheter and in the extension tubing. And if you go in there and just go whoosh with your flush, you're bolusing your patient with the medication, with the last part of the medication. Your patient can respond to that. Okay? And then you reclamp it, and you're done with it. One technique I want you to notice is, now this patient has an extension tubing, or I really think this is an IV tubing here. They've got a port, but you see right here what they're doing. They've clamped or crimped the tubing here. That's so that when they push the medicine in, it goes to the patient. It doesn't go backwards into this tube. Okay. So clamp your tubing and push your medicine in, and then unclamp it. Now when you clamp this right here, your IV thing's going to beep. Okay, it may beep if you keep it clamped for any length of time. Okay. You'll see nurses do that, and that's why they do it. If you're giving it slow enough, you may not need to kink it off, but it's okay to kink it. It's all right. It won't hurt you. I think I've got a video to show you that, and then we'll take a break, okay?
Administering medications through a peripheral line using the IV push method via saline lock. Prepare medication according to manufacturer's instructions for IV injection. Fill 2 syringes with normal saline. Label all syringes. Identify client and explain procedure. Check vital signs if indicated. Wash hands and don clean gloves. Cleanse needleless injection port with alcohol swab. Insert saline syringe into port. Open clamp if present. Briefly aspirate to check patency. Flush system and look for swelling or signs of discomfort. Insert medication syringe into port. And inject medication into vein. Timing injection administration rate according to drug manufacturer's instructions. Observe client for any adverse reactions. Remove medication syringe. Flush with second saline syringe to clear line and maintain patency of lock. If using saline lock with extension tubing, flush with same amount of fluid at same rate as medication to prevent bolus of medication. If more flush is necessary, inject slowly and steadily. Dispose of equipment and gloves. Document medication administration. Recheck client's vital signs if indicated.
Now, one of the things that they did was she cleaned off the site before she changed every time. If you can maintain the cleanliness of that hub, okay, you don't have to do that. If you can keep your hand on it, or just make sure it's not flipping and flopping and getting all in the bed covers, that kind of thing, it's okay. You don't have to do that. She was having to unscrew needles off of each one of those. A lot of your medicines now have the thing you can just pop off the end and screw that on, inject, and then you can still hold with one hand and pick up your next one and screw it on and inject. So, if you're able to keep that sterile and keep that, clean, then you don't have to swab in between all those, okay? It's pretty simple. Pretty simple. Questions about that? All right, one of the last topics that we need to talk about is blood administration and the administration of volume expanders. Okay? This is another RN-only job. Okay. And while PNs can monitor it, you're the ones administering it, I guess is the correct word I'm looking for. But when we're talking about blood, in order to use blood and its components properly, the nurse has to know the products and the uses of those products, has to be able to recognize risks and side effects, and the physician has to weigh the potential danger versus the expected benefit of blood administration. We don't just haphazardly give people blood and blood products. So what do you think are some of the potential dangers in giving somebody blood? Blood incompatibility, what else? Reactions, right. And disease transmission, right, disease transmission. So we got to look at those kind of things and look at those risks, and is the benefit outweighing the risk? So for this reason, the transfusion of blood or blood components is never routine. It is not given or ordered unless it is worth the risk to the patient. Reaction. And incompatibility. Okay. So it's never just a routine thing to give blood. So when we're talking a blood transfusion, there's different types of products that you may be giving. You may give whole blood. You may give plasma, which is usually fresh frozen plasma, FFP. You may be giving packed red blood cells. platelets. You may give albumin. So why would we want to give somebody a blood transfusion or a blood product? It may be that we need to increase the circulating blood volume of the patient. Okay. They've had some type of trauma, hemorrhage, maybe surgery. We may need just to increase the number of circulating red blood cells. Maybe your patient is anemic. Not routinely, no. It may be that we're needing to replace some of the cellular components of blood, like clotting factors, platelets. So lots of different reasons why we might give blood. Okay. Think back to your anatomy and physiology. Remember the blood groups? A, B, O. You got your RH positives and your RH negatives. Remember, bring that stuff back to your mind. Okay. Universal recipient is AB, right? Remember that? And the universal donor is O. You know what blood type you are? Good. Okay. Good. So when we're talking about types of transfusions and blood donation, there are different kinds, okay? An autologous donation or transfusion is when you donate blood to be given back to you at some later period. Autologous. Okay? Say you've got a surgery coming up and the physician feels that you're probably going to need to have some blood administered as part of it. You can, ahead of time, go donate blood for yourself, okay, anywhere from 1 to 5 pints. But it needs to be done far enough ahead of the surgery so that you're not anemic when you go in to have the surgery. Okay, so up to 5 weeks ahead of time, you can start donating. You may give blood as a directed donation. That means you're donating blood to go to a specific person. I know y'all have seen like blood drives for kids that have cancer and, you know, different families and things like that. That's what that is. The blood that's donated is earmarked for that patient, provided it matches that patient. Okay. And then you, of course, voluntary donation, which is just blood drives. You go and you give. Okay. Why not? Yeah, they're very particular about blood and who can donate and who can't. Do y'all donate regularly? Yeah, good. Okay. So when we're talking about blood administration, the RN responsibilities, this is your job here. Okay? You need to know what your hospital policies are regarding blood administration, what the policy and the procedure is. Blood always needs a consent. And a lot of your places have a specific blood consent. Okay, it's not like an informed consent like surgery, but it's a blood consent. The nurse is responsible for getting the blood from the blood bank. making sure that we have vital signs before, during, and after the transfusion. The RN is responsible for the transfusion and monitoring the patient. And also being able to recognize and intervene if the patient has problems. So basically, blood administration is your baby. As the registered nurse, you're responsible. Now, your PBNs cannot initiate it, okay, but they can monitor the patient. You have to start it, but they can monitor the patient during the transfusion. So they need to know the policies as well, okay. They can be used for identification, making sure we got the right patient and the right blood and all. We'll talk about that in a minute. And then they have to be able to, if you're going to let them monitor it, you got to know that they're able to recognize and report problems if they occur. Because it is ultimately your responsibility. Okay. So how in the world are we going to do this, and what do we need? First of all, I need a physician's order. And the order needs to tell me what to transfuse and how much to transfuse and when to transfuse, if that plays a part. Okay. This afternoon, stat, tomorrow morning, I mean, it needs to tell, but the physician will order 2 units of packed cells, 10 units of platelets. Okay. We will need necessary labs ahead of time. These are usually ordered. However, you're not going to give any kind of blood unless you have typed and cross-matched your patient. So what that means is the lab is going to get the blood type of the patient. They're going to do that test. And then they've got to take that and check it with the same type of blood that they have in the blood bank to see what is compatible. That's cross-matching. All right, so a type and cross-match has to be done. I'm sure you're going to have a CBC of some sort, a pretty recent one. Otherwise, you don't know if you need blood, right? You do need consent, like I said. And then a Finwall sticker is the sticker that we use for identification of the unit, patient. It tells everything has to line up. I'll show you that in a minute. But we use that for identification purposes unless we're having to give uncross-matched blood. Now, there will be times, like in your ER or surgery or maybe your ICU, that a patient may receive blood that has not been cross-matched. Okay? This would be in an emergency where the delay in trying to cross-match blood is detrimental to your patient. You got a patient that's bleeding out or a severe trauma, you got to get blood back into them. You can't give that. That's another one of those things where you got to have folks document that it, and somebody's got to sign, the physician, that, yeah, I need to give uncross-matched blood. Yeah, they just don't start handing that stuff out just because, the nurse calls and says that's what I need. There's got to be some documentation there, okay? No, they're not worried about it. What do they give in that? What's the universal? O negative. O negative is the uncross match that we give. That's the universal donor. Okay? Once blood is gotten from the lab, or the blood bank, I guess you would say, it needs to be started within 30 minutes. So when you go to get the blood, you need to be ready to hang it when you get back to the floor. And then that unit must be infused completely within 4 hours. So you got some time frames there to be concerned about. And then you also need 2 licensed people to identify all your stuff, your blood and your patient and all that business, and that has to be done at the bedside. Okay. So even before you go to get the blood, you need to have your consent signed. You need to have your patient's vital signs and assessment done. You need to have your IV going. So when you go to the lab, get the blood, you come back, you do all the identification things, you hang your blood and start it to infuse. So here's what we actually need in order to do the procedure. Of course, you got to do your vital signs. You've got to have your IV, a good IV, preferably with an 18 gauge. We can use a 20 if we just have to, but preferably an 18. Blood tubing is also called a Y set. And I'll show you a picture of it in just a minute, okay? Of course, you need a pole and a pump. And we always hang normal saline with blood. In fact, that's what we piggyback our blood into normal saline. Fine. You're confirming your order, getting your informed consent signed ahead of time. You're identifying your patient. You know that's a big deal. Some of your patients that have donated blood or that have blood already typed and cross-matched and sitting there waiting on them may have a blood bracelet on, in addition to their hospital ID band. Okay, it's like a blood bank bracelet. Okay, so that may be another numbers that you have to confirm. Okay, you always want to get your vital signs before you hang blood, including temp. Get you a good baseline. Listen to their lungs. Okay. Always want to do those kind of things. Wash your hands. You want to set up your IV site and prime your IV site with saline. What we do, blood is like I said, it's a Y tubing, and this is it right here. If you'll notice, you have one connector up here, and then you have another connector up here. It's a Y. Okay? Here's your filter. This is blood tubing. Here's your filter here, and then from here down to the patient, it's just like regular IV tubing. Okay. But if you notice, there's a roller clamp here and a roller clamp here. We always hang, one of these is for the blood, one of them is for normal saline, and it doesn't matter which one. Okay? So you're going to prime your tubing. Go ahead and hang your normal saline. Now, this is not something that you're going to take this setup and piggyback it into another line. All right? You need a separate thing for blood, a separate site. So either you got to stop your other IV fluids that are infusing and hook this one up, or you've got to stick your patient again. Most of the time, it's okay to stop your other fluid. And if you have an extension set on there, you just unhook it and hook this one up to it. Okay? But you do not piggyback this into anything or piggyback anything into this. Okay? So, in order to prime your tubing, the only thing different is you got this little extra thing up here. Clamp this off, spike your bag. Usually we put 500 cc's. We don't use the big bag in this case, usually. 500 cc's of saline. Open this up. Squeeze your drip chamber, which filter here, drip chamber here. So fill it up till it gets about halfway here. Okay. Then down at the bottom you have a roller clamp that you're going to just open it up and prime your tubing just like you do regular IV stuff. Okay? Clamp it off. Go to your patient's room, hook this up to your patient, and just let it be going slow. Okay? I usually hook it up and put it at KVO. Okay? Just to keep the vein open. I've got my vital signs. My patient's consent is signed. Now I'm going to go and get my blood. When I come back to the room, now what I want to do is I want to clamp this off and I want to spike the bag. No, the first dang thing I want to do is make sure I've got the right patient. Let's back up a little bit. I make sure I got the right patient, the right bag of blood, and I've got another licensed nurse in there with me making sure. Now, you're going to do this same procedure as far as validation and identification in the blood bank. When you go down there, you take the patient's chart. Do they go to the blood bank at Huntsville to pick up blood? They do, right? Okay. I know that's the way we do it at my hospital. But you take the patient's chart, you go to the blood bank, they'll have some type of identifying thing on the chart, a blood slip, form, something like that, that the blood bank tech will take to find the unit of blood that matches that slip. And then you and the blood bank person will compare. They'll be reading off the bag, the thin wall sticker. You'll be reading that form. Okay, you've got the right patient, the right medical record number, the right date of birth. You've got the right bag number. You've got the right bag type, blood type. Okay? They sign your form, you sign their blood book. And then you, the chart, and the bag of blood go back up to the patient's room. Once you get into the patient's room with another nurse, then you do the same thing. You're looking at the patient's ID band, comparing the ID band to the blood form and the blood bag. If it all matches, everybody signs the blood form on the chart, and then you're able to hang your blood. Okay? Yes, ma'am. You can mix. They are. They mix right here, but it's just saline. That's all you can hang with blood is saline. And you're not going to take this tubing and piggyback it into D5W. Okay. So to spike your blood bag, you're going to clamp this one off, spike your bag, and then you want to open this one. Only have one of these open at a time, because if you don't, you're going to have pink saline or diluted blood, because they talk if you've got them both open. Okay? So, and you'll have pink saline, just trust me, you will, until you get the hang of it. But if you'll only leave one of them open at a time, you're okay. All right? And leave the one open that you won't infusing. The one down here is handling your rate, et cetera, or your pump is handling your rate. Okay? But you and the blood will just immediately start to infuse once you open it up. Okay? So that's what a Y set looks like. When your blood has transfused and your pouch is empty, you're going to close this one, open this one, and let this flush out your tubing, flush out your blood. Okay. So go ahead and prime your tubing, hook it up to your patient, and be ready to go. Uh-oh, okay. You've got your two clamps, okay? What will happen is this one, if you open them both at the same time, this one will flow down and back up into here, and this one will flow down and back up into here. Okay? So right now, you've got your saline infusing. Okay? Spike your bag, close this one off, spike your bag, and then open this one, then this one will infuse, and the saline will not. Yes, you're priming it with the saline. Yes. Flushing your tube, getting the air out. Yes. Yeah, because you've got blood all up in this connection thing here and all the way down to your patient. You've got blood. So what you do is cut this bag off. I'm sorry, I can't do that unless I do this. I'm sorry. Cut this one off, open this one, and then this one will infuse and will wash the blood on out. Because you may be hanging 2 units. So if you cut this one off, get your let this one infuse, okay? Get your vital signs post-transfusion. Your patient's doing all right. You take the chart. You go back down to the lab. You get the second unit. They're only going to give you one at a time. Get the second unit. You come back up, all right, and you have you cut this one off. You spike this one, and you open this one up and let it transfuse. Yes, yes, yes. It's just priming the tubing. Just to prime the tubing. Mm-hmm. Mm-hmm. And then to flush your blood too. It's just, you just hang a, yeah, because if your patient starts to react, yeah, you may want to flush that out, and yeah, I see what you're saying. Yeah, you can, that's why we usually hang about 500. Yes, ma'am. Uh-huh. Mm-hmm, mm-hmm. You know how we, you're going to open this one and squeeze the chamber and it primes it on down to the chamber. It just when the blood starts to come down to this way, it will prime it, and you've got enough space in here that you're not going to put air down in your drip chamber. Yeah, I'm sorry, you were talking about the blood, not the saline per se. But you can always, if you don't think you have enough here that you may get air down in here, you can squeeze that and pull your blood on down, just like you did with your saline. Okay. You clamp the saline line, right. Yeah, because you'll shoot it back up in there. You will have peak saline. It's pretty, but you're wasting blood. You waste blood. So again, when you get to the bedside, you got to make sure you got you and somebody else. All right? These are your fin wall stickers here. This tells you that this is O negative. And there's a number here and numbers here. There's numbers all over the place on this bag of blood that you're comparing. That's your unit number. Okay. You have to do this before you spike the bag. Once you spike the bag, it's a done deal. Yes, ma'am. Yes, there's a roller clamp down there. Uh-huh. Correct. You can either unhook it, flush your line, and then connect it back up, or you can hang another bag of saline. Yeah, we don't usually just flush it. If your patient is having a true reaction to where you're having to stop the blood flow, you're not going to just open up your saline to flush your blood out, because where's the blood going? Into your patient. So you can either disconnect it and open it up, flush it into the garbage can, and then hook the patient back up. Or if you have another bag there, prime tubing and hook that up to infuse. Yeah. All right. Okay. These are just what we've basically talked about. Okay. You can infuse too, but I'm not going into that today. We'll let you get a little used to the concept first, okay? But if you only open the one at the top that you want to infuse or prime, you're okay. That'll keep you from having them mix, okay? When you hang your blood, you want to start it slowly. My hospital's rule is that we start it at 50 milliliters an hour, and we stay with our patient the first 5 minutes. But we run it at 50 an hour for 15 minutes. So you think about IV tubing that's this long, if not a little longer, and it's going at 50 milliliters an hour, and I've got to stay with my patient for 5 minutes. I got to. Okay. The patient is really not going to be getting a whole lot of blood in that time frame. So what I do is, when I've got my bag and I have primed my tubing and got the saline infusing, okay, I spike my bag of blood, and then what I will do is I will open that up until the blood comes all the way down almost to my patient. That way, when I put it on the pump and I set it for 50 milliliters an hour, while I'm in there, the patient's actually getting blood. You see what I'm saying? They're actually getting blood into their system. It's not still back up here in this tubing. So I just run it down. That's just something I do. You run it down close to the patient, and then you can see your patient actually get blood while you're in there. Okay, start it at 50, or go by your hospital, but start it slow. Stay with your patient, because if they're going to have a full-blown hemolytic reaction, it's going to happen within the first few cc's of blood. They're going to react quickly. Okay. If they're not having any kind of reaction, then you can go ahead and set your blood to infuse anywhere. Usually we go anywhere from 2 to 4 hours. Remember, the blood's got to be in by 4 hours. So your patient, you've got to look at your patient's age, their cardiovascular status, because the physician, if they order a rate, they're going to say slow. Okay. Remember, you got somebody who's got congestive heart failure, and we're giving them blood. We're putting in an extra 250 cc's of volume to your patient. Packed cells are 250 cc's. Whole blood is 500. Okay. Packed cells is mostly what we give. And if we're giving albumin, that's a volume expander anyway. So we really have to be careful there. So you can set the rate, at what you want it to infuse at. But you have that 4-hour limit. It may be that you're giving your patient 2 units or 4 units or whatever. You may have orders to medicate your patient in between units with Lasix. Okay? That happens sometimes. You may give your patient Tylenol. If in their cross-match there's some kind of weird antibody there, you may give your patient Tylenol ahead of time, or you may give them Benadryl. All of that will be ordered for you. That's not your call. That'll be ordered for you. Sometimes there are specific filters that you may need to attach to your blood tubing in order to transfuse blood safely. If there's some kind of weird leukocyte something going on, okay? But again, that's ordered for you. You are giving it in your other IV line. Or you've disconnected your blood, given your Lasix, if it's IV push, given your Lasix, and hooked your blood tubing back up. You're not giving that while blood is transfusing. Okay, you need to be clearing out you need to be having saline flowing through there. Okay. Some places, I know that we've done this, is if somebody's got to have a lot of, they're getting blood and they're still getting IV medications, and we've got to give them Lasix and do all that, we'll just start a saline lock for all that extra business while their blood's going. So use your judgment. Use your judgment. Is there a hard and fast rule? No, because your patient may not have another vein, so you may have to disconnect. The more you can keep from disconnecting, the better it is, but it ain't always that you don't have to do that. Yeah. Okay. So what do we see when our patient has a reaction? All right, they have a reaction to the antigens and antibodies because blood that is mismatched. You don't see this very often. I mean, this type and cross-match business, they have really, it's they've got it. They check everything. But your patient can still have some mild reaction, anything up from mild up to anaphylaxis. Okay. So when you get your patient's consent signed, you want to educate them on this stuff. You need to let me know if you have chills, if you're having back pain, okay, if you're itching. Okay? And remember, you're with them the first at least 5 minutes. Okay? So you're watching for this. I usually just have a seat and ask them about their kids and what they're doing for Christmas and all that business. You're in there for 5, you might as well be nice and visit. Okay? But you're doing nursing too. You're still looking at their site and making sure they're not getting hives all over the place. Okay? Fever, chills, rash, shortness of breath, tachycardia, all these things can happen. I think it's interesting that your patient complains of low back pain. Kind of interesting. And again, you may pre-treat your patient with Benadryl, Tylenol. That'll be ordered for you. So if your patient starts to have any of these signs, here's what you do. You turn off the transfusion And again, you don't want to flush through saline at this point. Like I said, you can flush your tubing and then reconnect it, or you can hang another bag of saline. You stay with the patient, have somebody contact the physician, go ahead and get your vital signs, and you need to do that every 5 minutes. You will get a urine specimen, because when they start to have anaphylaxis, what do? They break down that blood product, and it spills over into the urine. Okay? So you'll be asked to collect a urine specimen. You do prepare to resuscitate your patient. And you're always going to make sure that your blood, the tubing, the labels, everything is returned back to the lab so that there can be some testing done on that unit of blood to see why that patient reacted. Everything is taken down and sent back to the lab. Sometimes your patients will just have a very mild kind of reaction. And when you call the physician and give them a report on what's going on, they say, give them 50 of Benadryl and then start the blood back and give it very, very slowly. But again, it's not your call. You've done what you're supposed to do by stopping it until you find out otherwise. Most of your blood products come from the lab and the blood bank. So if you're giving albumin and those kind of things, all that stuff is going to come from the lab. And they require specialized tubings and that kind of thing. So they'll either give you the tubing or they will, it'll be available on your units. But platelets take an extra kind of tubing. Okay? What do you think you have to be careful with about platelets? Somebody said it, clotting. So platelets is not something, if you're giving individual units of platelets, that's not something that you're just got 4 hours to get it in. You shove those in, okay, because they'll clot on you. But y'all will talk about platelets and all when you start talking about hematology and all in 202, I think. Okay, but just regular old blood transfusion, you need consent, you need good identification, and you need the right setup. Okay, with the Y tubing. All right. Questions about that? Wow. No questions.